Thank you, Mr. Chairman, for the kind invitation, for the kind introduction. I'd like to thank the organizing scientific committees for inviting me to speak today. And second, I'd like to thank you all for being here and sticking with the program all the way to the end. I know you're all tired and probably overloaded with scientific content, so we'll try to make this as light of a lecture as possible. So I've been tasked with talking about combinations in IBD, past, present, and future. These are my disclosures. So the objectives would be to briefly discuss the rationale for combination therapy in IBD, discuss past and present experiences with combinations, including talk about pros and cons. Finally, we'll look at some future directions involving combinations in IBD. So, of course, we're not talking about a combination in a sense that we'd like to get as much as possible from drugs with the least cost, rather than we're talking about how to achieve a difficult task by combining forces between different medications. So if we take a real life scenario, please pay attention. This is probably the most scientific slide of the day. If we have a strong, big villain that shows up in town, we could either start by sending one superhero to combat this villain, but unfortunately wouldn't be able to overcome this bad villain. So then we can start by adding more superheroes to try and defeat this villain. But of course, surprisingly and interestingly, they probably wouldn't be able to exceed 30% after 6 months. Now, also in ulcerative colitis, I won't be focusing a lot on ulcerative colitis, but same thing with ulcerative colitis. This is data from ULTRA, and as you can see, even at 1 year with adalimumab, only about 30% net remission has been achieved. Moreover, after a period of treatment, a significant proportion of patients end up losing response to treatment, so secondary loss of response. Here we have data from ACCENT-2, CHARM, and PRECISE, and as you can see, about 1/3 of patients tend to lose response to anti-TNF agents within 6 months. This is a recent meta-analysis that actually did a good job of pooling data from all randomized controlled trials for all anti-TNF agents. And as you can see, the mean percentage of patients who needed an anti-TNF dose escalation was 23%, with an annual risk of about 18.5% per patient year. The random effect model here pooled incidence of loss of response with a median follow-up of 1 year to find it to be 33%. So 1/3 of patients lost response to anti-TNF agents within 1 year. So we have 1/3 of patients responding, or net remission rate within 6 months, and those that respond, we have about 1/3 losing response within 1 year. Now, the first sign of loss of response is usually the need for more medication. As you can see here with adalimumab, with time, patients require dose escalation, and that is usually the first sign that this patient is losing response to treatment. This signifies that we have developed secondary failure. Now, the causes behind secondary failure are multiple. It could be because some other organic process is going on, like infections, C. diff, stricture formation, bacterial overgrowth, bile salt diarrhea, overlap with functional disease. It could be due to the so-called increase in non-immune clearance or mechanistic override. But the commonest cause, or what is well characterized and recognized as the major cause of secondary failure, is actually development of anti-drug antibodies. And what happens is, over time, gradually anti-drug antibodies tend to develop because of an immunogenic response. And this usually parallels a decline in the concentration of drugs in the serum, which has been associated with poor outcome according to multiple studies. Now, there's a large variation in the percentage of development of anti-drug antibodies according to studies, ranging from 3% in very old studies, such as the present study, one of the first randomized controlled trials to investigate anti-TNF agents for Crohn's disease, and up to 17% in other studies. So in a nutshell, anti-TNF agents, although they are the cornerstone of treatment at the moment for Crohn's disease, unfortunately, as a monotherapy, there's lower than desired efficacy rates, high probability of loss of response. So what are the solutions? We can either go with drugs with different mechanisms of actions, like we heard in the satellite symposium from Dr. Ali, drugs that are selective for gut immunity, or we can maximize drug effects with what we have through TDM-based escalation. Finally, we can decide to combine drugs with different mechanisms of actions, either concomitantly or sequentially. So what has been done in the past with regards to combination? Now, why should we combine? Well, I just presented to you the therapeutic gap at present. We know that at 6 months, 30% efficacy at the most. At 1 year, 1/3 of patients lose response. There's also the quest to find the most complete treatment regimen for Crohn's disease or IBD in general. We often combine anti-TNF agents with immunosuppressants to reduce the chance of immunogenicity and hopefully give us a more durable response. Another scenario is to reverse immunogenicity, and I'll talk about that in a bit. And finally, we have PK improvement by increasing or improving trough levels. Of course, there's the concept of treatment synergy, which is not as well characterized at the moment. Like all good things in IBD, a combination treatment started in rheumatology, from the rheumatology literature, as you can see here in this study from 1998 in in Arthritis Rheumatology journal. Combining infliximab with methotrexate led to a decline in infliximab anti-drug antibodies and to improvement in serum trough levels. This was followed by an interesting study called BEST study, which was looking at infliximab in early rheumatoid arthritis. This is a multi-center randomized controlled trial that compared 4 treatment strategies. We have 508 patients that were randomized to one of 4 treatment strategies. Group 1, sequential monotherapy. Group 2, step-up combination therapy. Group 3, initial combination therapy with a taper of high-dose steroid dosing. And finally, initial combination therapy with infliximab. As you can see, when we look at the total SHARP score, which looks at progression in damage or joint damage, you can see that the group that received sequential monotherapy did the worst, and patients in the initial combination therapy had a higher percentage of no progression in damage score. This was followed by the, probably not the SONIC equivalent, but maybe the COMMIT equivalent in rheumatology, which was the premier study that combined adalimumab with methotrexate in early rheumatoid arthritis. And as you can see again in this large RCT, patients on combination therapy did significantly better than those on adalimumab monotherapy or methotrexate monotherapy. In IBD, the first group to probably look at this approach was the JITA. And in JITA study led by Dr. Liman, here compared placebo plus azathioprine versus infliximab plus azathioprine or 6-MP in steroid-dependent Crohn's disease patients. And as you can see here, steroid-free remission was more frequently occurring in patients on the actual combination compared to placebo plus thiopurine at weeks 12, 24, and after 1 year of follow-up. I think I missed a few slides. There's actually a couple of slides from the SONIC trial that were supposed to be on the screen, looking at both primary and secondary outcomes, comparing. I think everybody's familiar with the SONIC trial, which is one of the landmark trials in IBD that compared infliximab plus azathioprine versus infliximab plus placebo and immunosuppressant plus placebo, and there was a clear benefit with combination treatment across all endpoints. Subsequently, there were some PK studies that emerged from this study base, and you can see here that patients treated with both Imuran and infliximab had higher infliximab trough levels, and of course lower probability of developing immunogenicity after 6 months of treatment. Excuse me? There seems to be some problems with my slides.
How many slides to go, يا دكتور؟ دكتور محمود. محمود. يا دكتور محمود.
أيوة.
How many slides you still have? How many slides you still have?
Should I go back? Okay, so this is where I stopped. Yeah, there's some missing. Well, there was a few slides talking about, before this I was basically presenting a slide questioning whether or not, I've demonstrated that combining infliximab with Imuran is a fairly effective strategy. Also, there's a slide on data from COMMIT, although it was a negative study in the sense that the primary outcome was not met. There were some PK studies that showed that there was some benefit with regards to immunogenicity and trough levels. After that, there was a study I wanted to present, or a meta-analysis from the group led by Dr. Ala Sharara from Lebanon, that meta-analyzed all data looking at combining adalimumab with immunosuppressants, and there was no evidence suggesting that combining adalimumab with an immunosuppressant is superior to adalimumab monotherapy. So as opposed to the evidence we have from studies on infliximab combination treatments, there isn't much involving adalimumab or Humira. So now, one of the issues with combination therapy, so we've talked about the pros. Now, if we shift to the cons and the issues with combination treatments, of course, there's a concern about serious infections. Now, as you can see here from this data published in Gastro in 2008, you can see that the more addition of medications, the more chance we have of developing serious infections in IBD. So the odds ratio of developing a serious infection, for example, with infliximab, excuse me?
You have only 2 minutes to go, yeah, Dr. Mahmoud.
Sorry?
Dr. Mahmoud is not listening to me.
I'm sorry?
2 minutes to go, if you can conclude.
I haven't really finished half of my slides this way. Huh? We tested it was fine before. Anyways. Okay, so what should we do? Of course, again, this is a slide that should have presented all the guidelines from different societies, that basically there's a large conflict between societies with regards to what to do with combination therapy. So future directions, and again, this is the part of the study where I wanted to present on what is happening now with different combinations. And here we have a slide or a figure that showed how drugs with different mechanisms of actions work in a different way. And this is several studies that were published looking at case series and case reports where biologics with different mechanisms of actions are combined for IBD. This is a study from Bruce Sands where patients received both infliximab and natalizumab, and as you can see, there was actually a significant the proportion of patients that showed a good response with regards to CDAI, and more importantly, there wasn't any signals indicating that this approach is terribly scary in any way. Again, there's more studies in both IBD and rheumatology that have combined different biologics as treatments. Now, for future directions, as you can see, this is the study from the Serbian cohort, where patients with acute severe colitis received, who were resistant to IV steroids, received IV cyclosporin initially, and then were transitioned to oral cyclosporin after receiving also induction vedolizumab. Here, patients were followed up for up to 1 year, and you can see that a significant proportion of patients were still in clinical remission after a year of follow-up. So cyclosporin followed by vedolizumab is probably a reasonable approach, and I think we'll see more of this in the future. Another study, So some of the studies now you can find on clinicaltrial.gov, where biologics are combined. This is a study that combines vedolizumab and tacrolimus versus monotherapy with vedolizumab. The slide before this was looking at Explorer, which is a study looking at triple induction treatment with vedolizumab, adalimumab, and another immunosuppressant. So hopefully we'll find more results from these studies in the year to come. Now, take-home messages, and I apologize that I wasn't able to show any of my slides due to audiovisual issues, but although anti-TNF agents are effective for Crohn's disease and UC, there is still an unmet need for more effective, safer, and durable therapies. Combining anti-TNF agents with immunosuppressants yields higher efficacy, but with an increased risk of infection and malignancies. Several studies examining the efficacy and safety of combining agents with different mechanisms of actions are underway. Thank you very much.